diverse youth. And I'll be kind of focusing a little bit about, actually, why don't we just go through? So these are my disclosures, no conflicts of interest, but any medications that I'm going to be talking about are going to be off-label use. There are no FDA-approved medications for treatment for gender dysphoria. And some of the things we'll be talking about today, one, we're going to start off just by a little bit of intro to gender diversity and talk a little bit about health disparities faced by gender diverse youth. We're going to talk about the importance of an affirming clinical environment and how you can build that in your own clinic space. And then identifying a few ways to support gender diverse youth in the primary care setting and in other settings. And then I'll talk a little bit about some services that we offer at Seattle Children's Hospital. So starting with some background. So this is the gender unicorn. Many of you may have seen this. This is a pictogram that we often use with patients and families and healthcare providers to talk a little bit about what it means to be gender diverse or transgender, and to talk about the difference between things like gender identity, gender expression, and sex assigned at birth. So gender identity is really kind of who you feel you are in terms of your gender. There is no test for gender identity, and there is no, there's no marker for it. It is just really about kind of who you are inside your brain. Gender expression has to do with kind of how you dress, the hairstyles you wear, the clothing you wear, kind of in relation to cultural norms for gender. So gender expression, things that are perceived as more feminine here in the United States may be different than other places in the country or in other countries. And those gender expression may match somebody's gender identity. It may not for many different reasons. Sex assigned at birth, really has to do with what your genitalia looks like when you are born. The majority of people don't ever have any type of, chromosome testing or hormone testing to kind of, really look at that type of their biology. Most people, their sex assigned at birth is really just based on their genitals when they're born. And when those things match, when your gender identity matches your sex assigned at birth, that is something that we call cisgender. And when those don't necessarily match, so if you were assigned female at birth based on your genitals, but your gender identity is not female, so whether it's male or non-binary or something else, then that is what we would call transgender or gender diverse. And I just want to highlight that those are gender identity and gender expression are really very different than something like physical attraction and emotional attraction. And so when we ask about those questions or think about those things, it really is important to think about those differently. And I wanted to just make a note about terminology, because terminology, when we're thinking about gender, is really constantly changing. It has changed a lot over the last, 30, 40, 50 years. I am sure that it will continue to change in the next 30 to 40 to 50 years. And so I wanted to kind of, point out the more inclusive and more common terms that we are using here in the green yes column, and kind of what they have replaced, what terms that we used to use in the past. Generally, the terminology is becoming kind of more inclusive of non-binary identities. I think in the past, we used to think of gender as being very binary, either male or female. And we know now that that is not true. Even, for sex assigned at birth, there are many people that have differences in sexual development. And that is something that's not binary either. And the other kind of reason for the change is that the terminology has changed to become less pathologizing. So something like gender identity disorder, really had that connotation that there was a disorder, there was a disease, something wrong with you if your gender identity did not match your sex assigned at birth. And the terminology has really changed to, to be more inclusive and more celebrating of somebody's gender identity. So gender diverse is really the more common term that we're using now to kind of include really anybody whose gender, who is not cisgender. So whether they're transgender, non-binary, whether there's a different term they use. Some people identify as agender or gender fluid. All of those kind of fall, under the umbrella of gender diversity. Gender dysphoria is the official kind of medical term and diagnosis that is used. That is what's listed in the ICD-10 that we typically use for a diagnosis code. These other ones, gender identity disorder and transsexualism, are still listed in the ICD-10 and do still come up. And those are terms, that really are more harmful and can feel really stigmatizing for people. So we do try to avoid those. Sex assigned at birth is something that we use rather than biological sex. Even that is something that people are starting to shift away from. One thing that we sometimes do is really just talk more in terms of anatomy. So people with ovaries versus people with testosterone, estrogen-based bodies versus testosterone-based bodies can be really more accurate. And more can give you more information about somebody compared to sex assigned at birth. And then even when thinking about name and pronouns, many of the electronic medical record systems will still have like preferred name and pronouns kind of listed in the field that you can type in. And even that we've shifted to using chosen name and pronouns, really recognizing that it's not a preference. Your gender is not something you prefer one way or another. Again, it's part of who you are. And then the last two, kind of changing to using gender affirming rather than, I think cross-sex hormones and gender reassignment really kind of has that expectation that you're changing from one gender to another. It has that kind of really binary basis to it. And just changing to gender affirming really recognize that that's not the case for many. So just a little note about prevalence and persistence of gender diversity. This all kind of comes with a asterisk that it is really, really challenging to actually, measure the rates of gender diversity. There are many reasons why people may not want to disclose their gender identity. And it also kind of depends on the population that you are testing. So in the past, I think the kind of statistic that was always out there was that 0.5% of the population was transgender. And I think we are recognizing now that that was a very, very underestimated number because the way that we got those numbers was really looking at the number of people that pursued gender affirming hormones and gender affirming surgeries. Not everybody who is gender diverse is going to want medical care like gender affirming hormones or surgery for a variety of reasons. And so that 0.5% of the population really did not include many people, who were gender diverse who didn't want to or could not pursue gender affirming medical care. So there have been many more recent studies kind of listed at the bottom there that have tried to, to really try to look at what percent of the population is gender diverse. That has given really varying results. The highest number in any of these studies is that top one that was published in Pediatrics, surveyed a sample of high school youth, and that came up with close to 10% of US high school youth that identified as gender diverse. Again, that was a higher number compared to a lot of the other studies, but it also was a much more inclusive sample compared to some of the other ones that only surveyed in medical fields or had lower response rates. So I think the bottom line is that there are a lot of gender diverse people out there, even if we don't know the exact number or percentage in our population. It's also important to remember that gender diversity is more prevalent among BIPOC youth and adults, and that the studies that we have about the prevalence does show that gender dysphoria in adolescence does persist into adulthood. When we look at kind of the rates of gender diversity in adolescents compared to adults, it is about the same. So it does, I think a lot of times people wonder or question if this is sometimes a phase or something like that happens in adolescence. And the fact that these numbers are the same throughout the lifetime really shows that it is something that does persist. And one question that sometimes comes up is, why does this matter? And I think one of the reasons is that there are so many things in our society and our culture that are very gendered, even from before birth. So things like gender reveal parties, before a baby is even born, there is a lot of expectation and discussion about what their gender identity is and, who they're going to be when they grow up because of that. And so there's a lot of pressure around a young person related to their gender identity, I think whether we recognize it or not, because it is something that's so ingrained into our culture. And even after this, when you get into childhood, toys are always very gendered, and not only toys, but kind of expectations of professions after that. So, girls can be beauticians and boys can be doctors. And these are the things that kids are hearing from a young age. And then even as you get older, everything is kind of marketed in terms of gender. Even things like toothpaste, where we all know that there is really no difference between, men and women's teeth and the toothpaste that they need, but they are still marketed in this way. So, I think many of us look at something like this and say, like, that's ridiculous. Why would you do that? It doesn't matter. But if you are somebody who is transgender and, say you are assigned male at birth, but you identify as female, a simple thing like buying toothpaste, reinforces that there is something different about your body. And it just makes it so that it's a constant reminder, in everyday life, that this is something that is different. And over time, that can be really, really distressing. And this is especially true during adolescence, that this kind of constant gendering can be really, really traumatic. This was a quote that was from an 18-year-old transgender adolescent that, sort of gave an idea of how they felt. And I think this is something that for people who are cisgender, if you have not experienced that, it makes it really hard to understand what transgender and gender diverse people are dealing with and feeling on an everyday basis. And so, all of this kind of leads into why there are increased risks for a lot of different things for people who are gender diverse. So the risks that we are going to be talking about are not inherent to being transgender or gender diverse. There is nothing about, gender diversity itself that puts you at a higher risk for things like depression and anxiety. It's really because of the, the stigma and the pressure and the transphobia that is present in our society across the country. And I think in the last year or so, the last couple of years, really, I think this is becoming even more and is making it really, really hard for everyone, especially for gender diverse young people. And so this is a list of the number of health disparities that have been found to be higher in people who are transgender or gender diverse. So things like higher rates of experiencing violence, family rejection, homelessness, higher rates of alcohol use, substance abuse, depression, anxiety, suicidality, higher rates of engaging in risky sexual behaviors and sexually transmitted infections, a much higher rate of eating disorders, and then also higher rates of attempting suicide. This also, overall leads to poor health and lower rates of preventative visits as well. So many gender diverse people really will avoid seeking care because of fear of discrimination. And luckily, there are many protective factors that have been shown to decrease these risks. So there are a number of studies that have shown that when gender diverse youth are supported by their family, their schools, their communities, that they have decreased rates of anxiety and depression. And there was a big study that showed that just support by their families in their identity and being able to social transition, so wearing their hair and clothing in a way that matches their gender identity, that alone can decrease their levels of anxiety and depression to rates that are similar to their cisgender siblings and peers. And so those are the types of study that really show us that, again, it's not inherent to being transgender that increases these rates. It really is the societal factors. And that's kind of before you even get into the medical care. So even things like just for a transgender youth to be able to use their chosen name in a variety of settings, that alone decreases rates of depression and suicidal ideation. And then more recently, there have been more studies that also show that gender-affirming medical care is a protective factor as well and decreases rates of these mental health outcomes. And then school engagement is, such a big part of youth and adolescents' lives that that's also a really important place that they need support. All right, so I'm going to move on to talking a little bit about what you all can do in your clinics and environments to create a welcoming space for gender diverse youth and adolescents. So one of the main things that we often talk about is names and pronouns. So making sure that when you have somebody who uses name and pronoun that does not match their legal name or pronouns or legal name or gender identity marker, that you have a way to kind of identify that and document it and have a system that everybody can be sure to use the same name and pronoun. If you imagine that if you every time you went to a healthcare setting, if they were calling you the wrong name and using the wrong pronouns, you probably wouldn't want to go back there, very often. And this is something that happens all the time for gender diverse people. And there are many places, kind of in the healthcare process that people have to write down their name and their gender marker. With intake forms, anytime you have like an ID band that prints, it's going to show up on there. And so this is one place to kind of look at within your own organization as something that can potentially help. I know many electronic medical record systems like Epic have a really easy place to be able to document somebody's name and pronouns where it shows up really easily in the medical record system. The other thing is restrooms. It can be really uncomfortable to find a place that feels, comfortable to use the restroom when you are gender diverse. Most multi-stool restrooms are gendered. And so for somebody who is transgender, picking the one that feels comfortable can be challenging. For people who are non-binary or don't identify in those binary gender norms, that makes it impossible to find, a place that feels comfortable. So if you have any single stall restrooms in your facility, actually labeling those as all gender restrooms is kind of like one small sign that can show that, that your space is going to be accepting and supportive of this person. And then things like visual cues, having wearing pronoun pins, having pride flags in your clinic space, even if it's, just a very small place in the corner, is again, kind of, I think for many people who are gender diverse, these are things that they look for when they go to a healthcare setting to really decide, like, is this a place that I can actually tell somebody that I am transgender, or that I can tell them, the real name and pronouns that I use, or do I have to hide my identity because it's not safe? So little things like this can, I think for people who are not gender diverse, they may not even notice, a small pride flag in the corner of your waiting room. But for somebody who is, that is going to make a big difference. The other thing that we think a lot about is communication. So a lot of the communication that we use is really gendered. So, many people will say like miss or ma'am, or, many people, like when talking about children, saying your daughter, your son, instead of your child. I think this is kind of gendered communication is something that's really inherent to most of us and is really hard to change without kind of being very proactive about it and recognizing the kind of common gendered language that you're using all the time. And I think this is something that's really important when, especially when talking to gender diverse youth, but kind of also to build into your kind of usual communication style to make it easier. And so I think this is also true when thinking about like doing a HEDS assessment for an adolescent, avoiding assumptions of common things like gender identity and sexual orientation, because once you make those assumptions and ask questions assuming certain things, that is really going to make it hard for an adolescent to correct you and to be open about certain things. And so these are many of the common assumptions that we make. Again, gender, pronouns, sexuality, similar to family relationships. Like when a child is in there with an adult, we don't always assume that it's their mom or dad that's there with them. And so it's always important to ask. And I think this is really important, again, when talking with patients and families. So in the HEDS assessment, instead of saying, when asking like a sexual history, instead of asking, do you have a boyfriend or do you have a girlfriend, kind of being more open about like, are you interested more in people who are more masculine or more feminine, or, asking open-ended questions instead of assuming. And when we are asking questions like this, it really is easiest to keep it simple and keep it respectful. And so just asking simple things like, what name do you go by? I have your name listed as this. Is that right? And I would argue that that's something that's important to do for everyone, whether it's somebody that you know to be gender diverse or not. They may have a nickname. Some people use their middle names. Again, I think that's something that if you can build it into your usual practice, or the practice of your registration staff to kind of be checking people's name and pronouns, and they can document that in the medical record for everyone to be using. And really trying to normalize the question by, asking every patient, asking everybody that's in the room. Many people will identify themselves with their pronouns when they're introducing themselves to patients, or again, wearing a pronoun pin can be another way to kind of have a sign that you are somebody who is going to be supportive and open to communication. The other thing is really thinking about gender neutral language. So there's going to be many times where you may not know a person's name or pronouns. You may not be in a place to ask. I think this is especially true like when people are in the waiting room, in groups of people, where you're not necessarily going to want to ask what somebody's pronouns are or name kind of in a group of people if they're not that they don't know. And so thinking about using gender neutral language in that case, instead of kind of assuming somebody's gender identity and using their pronouns. This is also really important when thinking about documentation. So this is mainly for if you have somebody who you know to be transgender or gender diverse, especially in this day and age of electronic medical records and most patients having access to those medical records through the patient portal. Even if you address somebody by their correct name and pronouns, if you are writing your notes without the correct name and pronouns, patients are going to see that, and that's not going to feel great for them. I think the time that this is often the most challenging is with note templates, especially in places like Epic and Cerner. A lot of the the name and pronouns get pulled in automatically in the note templates, and so I think that's another place where it's helpful if you are able to document that in the medical record. It automatically pulls in that chosen name and pronoun if that's how your templates are written. So that's one important thing to kind of keep in mind as well. And then these are just kind of some examples of ways that we would kind of write somebody's gender identity, and then also sex assigned at birth, to make it clear, why you're using the pronouns that you're using. And then lastly with this, it is really important to think about confidentiality for pediatric patients as well. So if you have somebody who tells you that they are transgender, that they use a different name or pronouns during your confidential, adolescent HEDS assessment, it's important to ask, who have you talked to about this? Does your family know? Do your parents know? And if they haven't come out to their family, and if they're not ready to do that, then I would probably not document that in Epic to have like kind of their name and pronouns listed there, because that is something that their parents may be able to see, or if somebody calls to schedule an appointment or something like that, may kind of unintentionally out that patient. So that's kind of one caveat and consideration to this. And then this is, just some examples. I think this is mainly for in the primary care setting, the question of kind of when to start talking about gender. There really is no right answer. It is recommended by the American Academy of Pediatrics to ask about gender in kind of regular well child checks, kind of as part of your screening that you do for everyone. Gender identity does begin to form around ages 2 to 3. I think this is a common question that comes up in some of the developmental screens. But that's, at the same time, not everybody who is transgender is going to start identifying as transgender or experiencing that gender dysphoria at such a young age. So it is something that is important to continue to ask, again, kind of building it into your normal screening questions when you're asking about getting a sexual history and asking about drug use and things like that, also asking about gender identity to kind of open that door for people to be able to talk about it if they haven't had a chance to talk to anybody about it yet. And then these are some questions to consider. I think the question to ask really depends on the age of the patient, the kind of maturity level. For many adolescents, if you just ask simply, how do you identify your gender, or what pronouns do you use? They're going to understand what that means and be able to talk about it. For a younger kid, asking kind of a more directed question, like, do you think of yourself more as a boy, a girl, neither, both, something else, that can be kind of a more clear way to ask. And then, the other thing is just asking if people have any questions about gender. I think especially, if you are in a space or a community that is not, maybe not as accepting of gender diversity, it can be really daunting to ask about gender, for everyone, and just not knowing what kind of response you're going to get. And I think sometimes asking a question like, do you have any questions about gender, especially because it is something that's out there in the media and in the news so much now, can kind of open the door to discussion without, having a more direct question to a person about like, what's your gender identity, but just, do you have any questions about gender, can be another way. And then when you do have somebody who identifies as transgender or gender diverse, these are kind of the two categories of things that can be helpful to ask more about. So one is really understanding supports. We talked about those higher risks of depression and anxiety, and how family support and school support can really decrease those risks. And so asking questions like, who have you talked to about your gender identity? How did that go? Are there people that are supportive and using your name and pronouns, and support at school and home? And for people who are really supported by their family and schools and have already talked to anybody, to people about it, there may not be a whole lot more that you need to do. But for people who haven't come out to anybody, with their gender identity, it may be really helpful to help them navigate that and find those supports, whether it's online or at a GSA club at school or with a mental health therapist, just to know that they have somebody that they can talk to, to get support in that space. And then another thing that can be helpful is kind of understanding their goals. So, asking kind of how long they've been exploring their gender. Are there parts of their body that make them feel uncomfortable because of their gender identity? Are there things that they would want to see changing? And I think this kind of gets into, whether people may or may not be interested in things like social transition or gender affirming medical care. Everybody is going to have a different path when it comes to their gender identity and gender kind of exploration and gender expression. And so we don't want to kind of assume, what medications or hormones people may want just because of their gender identity, because that is going to be different for everyone. So, there are many adolescents who are gender diverse that are not interested in any kind of medical care, and that's okay. They, again, those kids wouldn't necessarily need a referral or anything else. But if somebody is interested in, in gender affirming medical care, things like hormones, then it's important to know kind of the resources that you have to be able to help them explore that. So this is kind of a little summary when it comes to best practices in communication and creating a welcoming environment. Just checking the time because I have no idea how much I'm talking, but am I okay? Yeah. All right, I'm going to keep going until somebody tells me to stop. So some best practices, don't assume pronouns based on a person's appearance. Again, it's better to respectfully ask. Do use somebody's current name and pronouns, even when referring to kind of pre-transition events. Don't assume what type of surgery or medical intervention a person desires. Again, it's important to ask so that you can help kind of connect them to the resources that they may need. And then know what information is pertinent to care, and only ask in those instances. If it isn't relevant, you don't have to ask. So I think, the last couple of slides that talked about the questions to ask, those are mainly things that kind of come up during, again, like well child visits, when you're doing the confidential heads assessment or whenever that happens for you. But if you have somebody who's coming in to see you, for a cold or a strep throat or a broken arm or something like that, you don't necessarily have to get into a whole discussion about gender. I think in those cases, it's really just making sure that you're using the right name and pronouns throughout the visit. But that's really it. And so I think for sometimes, like, if somebody really just wants to talk about, their sore throat, then it's probably going to feel pretty invasive if you start asking a bunch of questions about gender too. So I think, both for you and the patient, really, knowing what's relevant and then not necessarily focusing on things that are not, is something to keep in mind. So I'm going to give a brief overview of gender affirming medical care. This is a very brief overview, just to kind of give an idea. I know often in spaces like this, there are kind of varying levels of background and understanding of gender affirming medical care. And so I do have at the end some additional resources for people who are interested more in learning about the medical aspects of care that our clinic has created, but we don't really have time to go through all of that today. And so this is kind of just a basic overview of gender affirming medical care. When we think about gender affirming medical care in adolescents, one of the things that makes a difference in kind of the options for care that are out there is the stage of puberty that a patient is in. So for somebody who has not started puberty yet, there are no medical interventions that are appropriate or needed. And so for kids who have not started puberty, we really just focus on social and emotional support. For kids who are in early puberty, puberty blockers are something that can often be helpful if a patient is really, having distress or dysphoria with the puberty changes that are happening. Then puberty blockers are a great way to kind of pause those puberty changes from happening and progressing. Later in puberty blockers may still be helpful if there are still some changes that have not happened, like facial hair or voice deepening. Puberty blockers can prevent those from developing. And then once people get into kind of later adolescence, gender affirming hormones, things like estrogen and testosterone, can help to give them the physical changes that match more their gender identity. And just a reminder that all of these decisions are made in conjunction with families and parents and guardians. Gender affirming medical care is something that requires parental consent for patients who are under 18. So these are really, really group discussions that happen with patients and their families. And these are some of the things that we do before thinking about starting medications for gender affirming medical care. So we always do a thorough medical assessment. We usually would get baseline labs, kind of thinking about monitoring for some of the potential side effects of hormones, and then also monitoring the hormone levels themselves. We do often do a puberty staging exam for somebody who is who has not completed puberty, but also recognizing that puberty exam can be really distressing for many people who are gender diverse. And so I think we give a lot of we give a lot of, space for people to decline that exam. We talk about what the exam looks like before we do it, if we do. And many times people will decline the exam because of the distress associated with it. And in that case, we may do blood work to look at hormone levels for puberty staging instead of doing that exam. And then we really have, really detailed discussions about the benefits of puberty blockers or hormones, the effects that they would have, and then the risks as well. And again, talking about that with patients and their families. We also talk a lot about mental health support, especially for people who do have co-occurring mental health things like depression and anxiety. It is really helpful for most people to have, an ongoing mental health therapist to help kind of support them as they're getting ready to start medications and after they start them. And then again, thinking about caregiver readiness. So it's not only the patient's readiness to start medications, but making sure that the family is supportive and consenting as well. And then these are the kind of common hormones or medications that we would use. So for somebody who is assigned female at birth and is interested in more masculinizing changes, testosterone is the main hormone that would be used. Menstrual suppression is another thing that is often really helpful for people who are having menstrual cycles if those are distressing. And that's something that is done a lot in the primary care setting as well. I'll talk a little bit more about that in the next couple of slides, but I think that is that for many people is kind of the first thing that they choose to do while they're kind of deciding on whether testosterone is something that they're wanting. For people who are assigned male at birth and interested in more feminizing changes, estrogen is kind of the main hormone, or estradiol, that causes those changes like breast development, curvy body shape, things like that. We often will also use androgen blockers to prevent or decrease facial hair and body hair, which estrogen does a little bit as well, but kind of the combination of estrogen and androgen blockers seems to work better for that. And then progesterone is also sometimes added after people have been on estrogen for a couple of years. I'll talk just a little bit about menstrual suppression again, because this is something that often happens in primary care. It can be really helpful when menstrual bleeding is a major stressor. They can be used in conjunction with testosterone or alone. For people who are starting testosterone itself does work fairly well to stop menstrual cycles for most people after they've been on it for 6 months or so. But sometimes people really don't want to wait 6 months for their menstrual cycles to stop. Or if they're not ready to start testosterone for whatever reason at that point, then they may choose to start menstrual suppression first to kind of have that suppression earlier. So the medications that we use for menstrual suppression are all the same things that you would typically use for contraception. So these are all medications that you're probably very familiar with. People can use the progesterone-only methods or combined progesterone and estrogen. I would say most of the time, people who are gender diverse feel more comfortable choosing a progesterone-only method, even though, if they've already gone through all of puberty and are having menstrual cycles, likely, estrogen is not going to have any additional effects on their body, but they still just may not feel as comfortable, taking that as a hormone. And so it really is about kind of patient preference and what they're going to be most reliable with. And then also considering if contraception is needed, because some of the progesterone-only pills are not as effective for contraception. This is one of the tables that we have on as a handout for patients to kind of talk about some of the different options. The progesterone-only pills, norethindrone acetate, or agestin is the brand name, is probably the most common one that we use, just because it's easy to start, it's easy to stop, it has really low side effects, and it works really well for menstrual suppression. And so this can be an easy one to provide if somebody is interested. I think the main downside is that people really have to take it at the same time every day to avoid kind of irregular bleeding or spotting, which sometimes can be hard for adolescents. And then, this just says it. The other thing that's great about agestin is that you can titrate the dose. So usually we start at 1 tab once a day. But if somebody's still having bleeding or spotting, you can increase it to 2 tabs once a day. The other downside is that this is not an approved form of contraception. It's not that different from like the mini pill that is used as contraception, but it has not been tested in that way. So if somebody is having, sexual activity with a partner that makes sperm, then we do usually recommend a different option that has contraception as well. All right, and then I'm just going to take 1 minute to talk briefly about the Gender Clinic and kind of the resources that we have here. So the Gender Clinic at Seattle Children's has been open for 7 years now. We are located in the Adolescent Medicine Clinic, and we see patients between 9 to 16. For patients who are 17 and up, there are many adult primary care providers in the Seattle area that see gender diverse adults, and so we often will refer to those people for older youth, just to be able to maintain our access for younger adolescents. I know for a long time we had an extremely long wait list. I will say that is much better, so we are able to get kids in within a couple of months at this point, which I think has been really helpful for them. And we are a multidisciplinary team, and so this is kind of the list of people that we all work in conjunction to support gender diverse youth. These are the services that we provide. We really focus on the gender affirming medical care, like pubertal suppression and gender affirming hormones. We do have a lot of mental health supports and provide kind of short-term mental health assessments and brief interventions, but we do not provide kind of long-term mental health therapy. We usually connect people to therapists in the community for that. And so really the primary reason to refer is if people are interested in gender affirming medical care, or if they are considering it or wanting to learn more about it. And then just wanted to highlight on our website, we have a number of resources for community providers that we've really been working to build up over the last couple of years. So again, if you are interested in learning more about kind of the medical aspects of care, or just wanting more, education materials for others in your clinic, feel free to check out our website or reach out to me. And then we also have a number of resources for patients. So if patients have questions about things that you are not sure how to answer, we have all of our kind of patient education handouts available on our clinic website that is available for anyone to look at. And then another thing that we have started in the last couple of years is an e-consult. So this is something that you would do through Epic CareLink. It is open to any provider in the state of Washington. It can be for any patient, whether they've been seen in the gender clinic or not, although it is only for youth who are under age 21, since we don't take care of adults there. And it's something that you just submit a question, and then either me or one of the other docs in our clinic will respond via Epic CareLink within 3 business days. This is currently something that is free for anyone to use. I am told that potentially will be changing at some point in the next, several years, but right now it is something that doesn't get billed through insurance. It's free for anyone. So so we welcome those. And then this is my final slide. So just kind of a summary of how can you support youth in your clinic. One, to create a welcoming clinical environment like we talked about. Really focus on using gender affirming language, in your communication, in your notes, in written materials in your clinic. Know where to find resources to support patients and families. Think about menstrual suppression for people who are having distress and dysphoria around their menses. And then have, kind of a basic understanding of gender affirming medical care and when to refer for that. I think that's it. All right.
So just a reminder that if you want to ask a question, just raise your hand. And I failed to mention, if you could just say your name and your clinic, just because I think networking is so important. And a lot of us probably know each other, but like, oh, that's who that is. So if you have a question, just name, clinic, and then of course the question.
I'm Jessica Almaguer. I'm Catholic primary care nurse practitioner. Is the e-consult just for providers or can patients and families send messages?
That's a great question. It's just for providers. Yeah, just for providers. We do have, like a MyChart messaging system for our own patients, but for patients outside of our clinic, it's just for providers. Thank you.
Alphabet soup question. GSA? Just what's GSA?
Oh, sorry. GSA is the
They can't hear unless it's on the mic, they're online. Sorry.
that's okay.
Just a question. You used the abbreviation GSA. Looked it up, couldn't
Yes.
find it.
Sorry, GSA is Gay Straight Alliance. It's a very common club that is in many schools that can be kind of an inclusive place for gender diverse people too. Thank you. I know the last person was talking about the alphabet soup, and I do that too.
Thanks. Guess I had also a question about a abbreviation BIPOC.
Oh, yes. So BIPOC stands for the Black, Indigenous, or People of Color.
Oh,
Yes.
okay. Also, I had another question now. Given the importance of how important it is to discuss the name proper, the chosen identity and the chosen name too. At what ideal age or how do you approach asking that when a patient comes in?
Yeah, I think for, there's a couple different ways to do it. I think one is to, to ask every patient, no matter their age or what they're coming in for, what name you would like them to or what name they go by. So you can either address it as like, this is the name I have listed. Is that the right name for you? And that's also something that can happen at a registration desk. It doesn't necessarily have to happen, in your own visit with the patient. But I think we usually recommend for anybody asking what their correct name is, whether they are using a different name, because of their gender identity or for other reasons. But if it is because of their gender identity, at least that is, is something that can open the door and to make sure that you are using the right name. Pronouns, I think, is something, that varies for everyone. Some people will ask, every patient in every encounter what pronouns they use to kind of make sure they're using the correct ones. Or again, that's also something that can happen at registration desks. That's what we do at Seattle Children's, is when patients are registering, they verify the name, the address, the phone number, their pronouns is kind of part of the process. I think for most people, kind of the time to really start asking more directly about gender identity is in kind of the adolescent years, like when you are when you are starting to have those kind of confidential heads assessments with patients during their adolescence. I think that's often when many people kind of incorporate more direct questions about gender identity. But
so ideally at every visit at the registration desk, as you pointed out, they the patient should be asked, what pronouns do you prefer? Or is it chosen? I shouldn't say that you choose. So in front of the parent, that might be a little awkward.
Yeah, it might be. And I think that's something that, is going to be may not be realistic to do in every clinic everywhere. But I would say that at least the chosen name, would be a good start, again, because that is something that can be different for so many reasons, nicknames, middle names, things like that. And then at least if you have somebody who, in front of their parents identifies that they are using a name that is very different from their legal name and is more associated with a different gender identity, then at least that kind of flags for you that, oh, this is somebody who may be gender diverse, and you can ask more questions about that.
And just one more question. Is there any future clinics here in the Tri-Cities for gender clinic? Is there any plan for that? Please.
That is a great question. We have had some discussions of expanding to the Seattle Children's site in the Tri-Cities. It has not happened yet, but that is something that we have talked about. So we'll keep you all posted if that does happen in the future.
Hi, Michael Kabasic, Family Medicine. Do you have any data on the severity of depression and suicide rates for those who have gone through gender affirming care?
So I do not. I know that there are more studies now that are looking at kind of the changes in rates, and they do show decreased rates of depression and anxiety and suicidal ideation. One of the studies that was based out of Seattle Children's, I think the biggest number from that was that there was a decrease in suicidal ideation by 70% for people after accessing gender affirming medical care. So the rates do decrease a lot. I don't have the actual numbers of like the prevalence in the group afterwards, but it does decrease.
Hi, I'm Eva Chavez. I'm one of the pediatricians with farm workers in Yakima. I have a couple of questions. Is the e-consult like specific for like gender clinic and like medications and stuff like that?
It is specific for gender clinic. I think there's been discussion of children's opening that up more broadly to different places, but right now we only have the e-consult for gender clinic. But it's not only for medications. We also have our mental health therapists and social workers answer those questions as well. So if you have questions about, something that's not related to medication, but it is about gender, you're welcome to use the e-consult for that too.
And to start medications, do you need both parents? Consent.
Yes. The bottom line is yes, any parent that has medical decision making needs to consent, which is often really challenging. I would say if you have, a family where like one parent is supportive and one parent is not, we are always happy to see that patient. And our mental health therapists do a lot of work with families. We also recently have started like a parent support group that sometimes that can be really helpful if parents are really struggling. But yes, if a parent has medical decision making, they do have to consent.
And are you finding that these medications are being covered by state insurance?
Yes, in Washington state, yes. I feel very fortunate that the state insurance and really all of the insurances cover gender affirming hormones, puberty blockers, even surgeries are being covered by Washington state Medicaid, which is amazing.
I have a question here on Zoom wondering about support approaches with patients that are having genital concerns but refuse a physical exam.
Yes, that is really, really hard. I think, it's really hard. I think one is to, try to meet the patient where they're at. There's like, obviously it's never appropriate to force a patient to have a genital exam if they are not comfortable with that. And I think, being really open about like, if there are things that you can assess, with blood work or urine testing or something like that without doing an exam, kind of trying that approach, but also acknowledging to the patients the limitation of that. If there is something that you really have to, do an exam to diagnose, then there may be limited options for what you can do. But I think sometimes, trying to do other things like labs or urine testing if you can.
My name is Kishore. We practice psychiatry in town, have several patients, and fortunately our EMR has got, biologically female and want to known as this and all that. But we do face sometimes several problems from the insurances because their insurance card will say something else. So we encourage them to go and change it and all. Are there any other measures you take when they have problems with that?
Yeah, that's a great question. And it sort of depends it depends on if a patient has had their name legally changed or not. I know, in our EMR, there are separate fields for kind of chosen name, legal name, because if they haven't had their name legally changed, they're probably not going to be able to change it, in like, if they don't have like actual state identification that has their name, they're likely not going to be able to change it in their insurance and in other places. So there may not be really, solutions for changing it everywhere if they haven't had it changed legally. But for somebody who has had a legal name change, then we usually do, they kind of have to go through everywhere to show that documentation to have that changed so that it is all consistent.
Emily Chow, pediatrician. Can you clarify about the parental consent to start medication? At what age does that apply up to?
Yeah, so gender affirming medical care is considered kind of standard medical care. It does not fall into the reproductive health care or mental health care. So it is up until age 18 that patients would need parental consent. I think the one caveat is maybe menstrual suppression, because that is not specifically gender affirming medical care, and it's mostly contraceptive medications. That likely falls more into reproductive health care, but things like puberty blockers, gender affirming hormones, it is up until 18 that patients need consent, parental consent for.
All right. Well, thank you so much. I really appreciate your knowledge, Dr. Hodax. Thank you.
Thank you all for having me.
All right. And then just that one question, Dr. Chavez, with the consult. Seattle Children's is in the middle. Some clinics are already doing it. Supposedly come the end of the year that there'll be more clinics added. So more to come.
Yeah.